Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day. While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, hello there. Thank you so much for electing to join us. We know there's a lot of things pulling at your heartstrings and your wallets and everything else on the weekends. We're so glad that you've chosen to spend a little bit of time with us. I guarantee you that it will be fruitful. One of the things that we've been doing over the last year, plus a year ago plus, is getting together with Dr. Juliff, who is the medical director of Vein Clinics of Hawaii, and talking about all of the really interesting things, some cosmetic, some fun, some aesthetic stuff that's really, really fun, and sometimes not so much fun. I don't know if you are a Preparation H user, but that should give you some sort of an idea where we're going to today, because I really didn't understand that there are many other kinds of vein disease that we haven't talked about. And even though we maybe broached this a couple of times very in passing as some of the symptoms or some of the things that happen to people is hemorrhoids. And I just guessed, I had no idea, Doc, until you sent me the list of things that we're going to talk about, that hemorrhoids was a venous condition. I just thought they were just little horrible things that happen on their own.
Yeah.
What are they anyway?
Well, they are veins, and they're along the lines of a varicose vein. But they obviously happen in a little different area. But they are, dilated veins, that, occur in the, lowermost portion of our,
of
GI
your bowel.
tract.
Yeah, the GI tract. That's the reason why I thought it was so compelling that we talk about this, because most of the people on the street don't say, "Hey, how you doing? I got hemorrhoids." I mean, they just don't do that. But maybe if they want to know about, okay, first of all, when you have them, if they're really bad, how do you treat them?
Right.
Not just rub stuff on them.
Yeah.
And then what about, well, this is indicative of you getting this over and over again. Maybe there's something going on with you that we better look at.
Yeah. Hemorrhoids are one of those things that, people don't like to talk about.
Yeah.
They like to talk about those even less than they do their varicose veins. But I thought, the hemorrhoids is a vascular kind of problem. And, at least this will give people something to think about and open the door if they're having these kind of problems, But, the GI tract, I think most people know, we swallow things. It goes through
and who knows what there are. I mean, look at all of the stuff we ingest. Right?
Yeah. But it goes down into the stomach. Mm-hmm. The stomach is actually an organ. Mm-hmm. Some people refer to the outer part of their abdomen as the stomach, but the stomach is an organ. So then the food goes through the stomach and then into the small bowel. There's several sections of that, and the small bowel is very long, but nutrients are being absorbed, etc. And then it goes from the small bowel into the large bowel. That's about 3 feet worth of large bowel, and then it gets to the lowermost portion of the GI tract, and it's there's a short little section of the GI tract called the rectum, and then beyond that the anal canal,
and then it's gone.
Yeah, and then it's the outside.
Yeah, now it's used food. It's out there somewhere.
Yeah,
but I think that it's very interesting that we're going to do this today for a couple of reasons. Because I'm guessing most of the people say, "I have a friend that needs to know about this." Because that's one of those things.
Exactly.
But what I think is fascinating is that I bet you that 90% of the people that are listening that have heard us before didn't relate that hemorrhoids were a venous issue.
Yeah, I think most people don't.
Yeah.
And that's the other reason why I wanted to kind of talk about this today is to explain it to people and also to define it. I mean, we've talked in the past. You've asked that question. Gee, aren't people happy when they come in and you tell them what they have?
Yeah, to find out what I got.
Yeah. And so and hemorrhoids can be fall into that category because people don't like to talk about it. At least hopefully we can add some definition to it, let them know that they're not alone because it is a very common problem, and also describe some of the easy fixes because technology, the same way that it has improved over the last 10, 15, 20 years for venous disease of the legs, it's improved in those other areas too. So it's pretty simple and fast sometimes.
Well, I'm fascinated that we're going to talk about this, and obviously, there's different tests and different things we're going to do. The first thing that comes to mind, though, and I'm sure people are sitting there thinking, hey, what causes them? I mean, why don't we all have them? I mean, and if you have them, does that mean you're doomed to have them forever and ever?
Yeah.
What makes this condition happen?
Well, hemorrhoids are actually normal veins. Again, just like varicose veins. Varicose veins start out as normal veins, and hemorrhoids do too. And they are veins in the lower rectum and the anal canal. Basically, for whatever reason, and probably for a variety of different reasons, the walls of the veins start to weaken. The vein dilates, and then it becomes more susceptible to the environment around it.
Sure.
And then it just kind of snowballs from there. So as they dilate, as these veins dilate, then it creates a certain amount of inflammation. Again, very similar to varicose veins. I mean, when varicose veins form, there's developing inflammation around them, so you can the area, the skin and the area around that then gets irritated, inflamed, itchy, and
now pretty soon you got those symptoms that they talk about, right?
Yeah,
the burning, itching sensation, right?
Yeah, exactly.
Is it made worse by diet? I mean, what if you've got hemorrhoids really bad, and then you eat really spicy stuff? Isn't that not a good idea?
Spicy, people talk about that, but is diet important? Absolutely. We're going to talk about that a little later.
Okay.
The type of food that you eat, not necessarily spicy. Although, that's kind of the quintessential, comment about spicy food, But, but diet is very important, and when we talk about treatment here in a few minutes, we'll go over that. But, the other thing is swollen hemorrhoids. And again, hemorrhoidal veins are normal veins. When they get swollen, then they are, creating a pathologic kind of thing. Sometimes they're called piles. You've heard people refer to as hemorrhoids as piles. And also, like varicose veins, it's a very common problem. Actually, hemorrhoids are probably a little more common than vein problems with the legs. And roughly, it's about 75% of adults in this country over the course of their life will have some sort of problem with hemorrhoids at one point or another. So it's very common.
Yeah, and I would imagine, I'm just guessing that cleanliness and hygiene and a lot of things come into play.
Sure, you bet.
And particularly in some segments of the society or community that aren't able to fend off this thing. But outside of it being irritating and maybe burning or whatever, can it cause other kids?
Can other bad things happen?
Yeah.
Yes, they can.
Yeah, I was wondering.
We're going to talk about it just in 1 minute. But let me say this: there's two different types of hemorrhoids, and I don't want to get too anatomic, but it's important because of the fact that there are what we call internal hemorrhoids and external hemorrhoids, and basically all that means is that the internal hemorrhoids are hemorrhoids that are a little higher up.
Okay.
They're sort of in the lowest most portion of the rectum, and those veins are connected, and it has other implications that we're not going to go into. But those veins are associated or connected with the vascular system of the GI tract itself. We've got obviously there's blood going in and out of every part of our body. The system within the GI tract is a little different, and therefore those hemorrhoids are a little different. The other type of hemorrhoid is an external hemorrhoid. It's more in the anal canal.
Yeah, I was going to ask you about that because I think that people wouldn't relate to which was one that you can put a cream on or something
Yeah.
that you can help yourself, and one that you need
Well,
something else.
Usually the ones that people are putting the cream on because they have itching and irritation.
Sure.
Typically, those are external. And the reason that that's happening is because external hemorrhoids have more to do with the circulation of the skin
Okay.
around the anal canal. So part of it is GI circulation, the internal. Part of it, external, is part of the skin circulation. So, basically, the external hemorrhoids are a little lower down. You're going to feel them, and they're going to be more irritating.
Yeah,
so,
people.
topicals are one remedy.
Don't some people, Doc? Do you have to use special pillows? Seats. You see people wandering around with looks like a little inner tube, but it's not. They can't sit down. Some of these folks, it's that bad.
Yeah, right. And those are external hemorrhoids. The thing with respect to that with internal hemorrhoids is they may not cause pain.
Oh, okay.
Yeah, because
different symptoms.
Different symptoms, and like the circulation, the sensory nerve system of the GI tract, which is the internal hemorrhoid, is a little different than the skin. Our skin has millions of little nerves that are going to be activated when there's something bad going on. You don't have that with internal hemorrhoids, so you may not have pain, irritation, itching, etc. With internal hemorrhoids, but they do bleed. Internal hemorrhoids.
Yeah, that was my question right on the top of it, and I know we're going to get into that. Some of these things that are bleeding, and when you ask a question or when you answer a question, like at Vein Clinics of Hawaii, when you do your questionnaire and you put in the information, is it do you blood in your stools? There's all these kind of things that you maybe not associate with veins. But that's exactly where it comes from.
Yeah, sure. So the only symptom of an internal hemorrhoid might be bleeding. You're not going to have pain, or you're not going to feel it because it's a little higher. Typically, you're not going to feel it.
But doesn't that scare people to death when they feel something or they get the runs or something, and then there's lots of blood in the toilet?
Yeah. Well, and it should.
Yeah.
Any amount of bleeding that is coming out when you have a bowel movement or on your stool or whatever, typically it needs to be evaluated.
Yeah.
Even if you think it's just from hemorrhoids, you really need to have that looked at. But so external hemorrhoids are a little different in that, again, they're going to be painful, irritation, itching, etc. They can also bleed. Yeah. But you're going to have other symptoms that are going to probably inspire you to have it looked at or whatever, or do something about. So
that now, in that case, let's say that there's somebody sitting out there right now. Excuse the expression, because that's what they're doing.
Yeah.
And sometimes it's muy uncomfortable. Is it reassuring when somebody finally decides, look, I've had this. I'm so tired of this and that, putting all this stuff on me. What in the heck can I do to fix this?
Yeah. Well, you need to go to the doctor. Yeah. There's no, if you have those kind of symptoms, again, like we talk about so often, you're having symptoms and it's not normal. You probably shouldn't ignore it, and it needs to be evaluated no matter what it is. It may be a simple problem, it may be a simple fix, but you don't have to live with that.
One of the things that I find fascinating, see if you agree, that this whole system that you're talking about, from the esophagus to the stomach to the this to the little to the big, unbelievable piece of equipment.
Oh, yeah.
Yeah, it really is fascinating.
It's amazing.
But look at all the things that can go wrong.
Yeah.
So you almost have to be on your toes all the time. And I would imagine if you don't do something, once symptoms are prevalent or you feel it, that you're really making a bad mistake. You need to get this stuff treated.
Well, you're putting yourself at risk.
Yeah.
Because, especially blood in the stool, for instance, it's not just, gee, do I have hemorrhoids? It's, gee, do I have something a lot worse than hemorrhoids? Because there are other things that can cause bleeding in your stool that are things that really need to be attended to. Cancer being probably the primary
number one.
one.
Yeah, but by the way, when you're talking about the symptoms and burning and itching, it is described as burning, right? And you'll see ads on TV and stuff where they'll actually show flames.
Yeah.
So it does get that much attention.
Right.
Is it because of the causticness of the fluid? Why does it burn?
I don't think it's that as much as it is just the fact that, again, these veins, they dilate, and an inflammatory.
I was going to say, are they getting infected or inflamed?
Well, not infected necessarily, but more inflammation. I mean, there's they become enlarged, they become traumatized more. They in a real inflammatory kind of process is occurring, and that's what then creates the discomfort, the irritation, and then itching comes along with it. I think probably for a number of different reasons, but not necessarily the caustic nature of what's going through.
What do people go through when they going to call your office or go to a clinic when they finally realize is, you know what? I hate talking about this. I don't want to go see anybody, but I can't stand it. So I've got to, excuse the expression, got to bite my lip and go get this thing looked at.
Yeah.
What's the process? How do you determine what's going on with somebody that has those symptoms?
Well, we don't. We have plenty of patients who talk about it because it seems that there probably is a connection between lower extremity venous insufficiency and hemorrhoids. Some of the risk factors are the same, so it's not unusual for people to have both. I don't do the procedural kind of stuff to treat hemorrhoids, but we certainly hear about it. And I give people my recommendations.
Sure.
But typically what I'm going to do is, especially, again, if their symptoms include bleeding, I'm going to recommend that they go to, a doctor to have it fully evaluated, which is more than, usually you need to have a scope and,
Sure.
look up there and make sure there's nothing other than a hemorrhoid as a problem that may be causing the bleeding.
Well, one of the things that I find fascinating is what drew you to the specialty that you do. You went through general surgery, cardiac surgery, and all of this stuff.
Yeah.
It also must mean that there are enough docs out there that know how important of a system this is, and it can be a real problem if you don't get these things dealt with. So it must be very rewarding, even though it's probably, somewhat difficult to deal with. It must be very rewarding to these people. Otherwise, you wouldn't find somebody that was willing to work in.
Sure. Yeah. And like I said before, often it can be an easy fix. Again, just like lower extremity venous stuff. I mean, it's an easy fix, and people have a tremendous, symptomatic relief and are happy, from that. So, anyway, so what happens with hemorrhoids? Once they form. So, the hemorrhoidal veins are normal veins that become enlarged. And then what happens? What are the other bad things that can happen? Well, number one, three things, basically. They can prolapse.
Which?
They can bleed.
Or what's prolapse?
They can clot off. So, prolapse, bleeding, thrombosis, those are the three, bad things that can happen. So what does prolapse mean? Well, that just means that the hemorrhoidal tissue has become enlarged and traumatized enough for it to actually come out through the anal canal so that you can feel it, And does that mean that it's either internal or external? No, it could be either. Probably the hemorrhoids that are enlarged and firm and tender, et cetera, most of the time those are external type hemorrhoids. But internal hemorrhoids can also become large enough to actually come through the anal canal.
Is that a bleeding problem? Is that going to be a problem later on?
It's potentially it's potentially a bleeding problem. But so why does this happen? Well, it happens because of the fact that again these veins are dilated, and each time you have a bowel movement. If you have inflamed, enlarged veins in that part of your GI tract, that hemorrhoidal tissue is traumatized each time that you have a bowel movement.
Sounds it, sure.
And especially in people who tend to have harder stools, and that's why we'll get to diet a little later. But diet is so important because you have to kind of there are things that you can do to alter the the quality of your stool. So in people, especially who have very hard stools, they have to strain a lot. And each time that they have a bowel movement, that tissue is traumatized more and more. until the point that the surrounding tissue around those, vascular structures, those veins, become stretched out and not as elastic, and that tissue, that vascular tissue, then falls down through the anal canal and is popping out.
Yeah, and by the way, I do know that I've heard this. A friend of mine who was an emergency room doctor years and years ago said that sometimes it is so bad that people they injure themselves. They don't know what's going. They're just trying to get it out of there, whatever it is. But it makes one wonder. It's. I guess there's topical things that we talked about a little bit. There's creams and things,
right?
But but when you said bearing down, was it straining? Isn't that another big area of concern?
Well, yeah, it is. People who have to strain a lot when they have a bowel movement, and typically those people. The people that do have to strain a lot are the same people that have a very hard kind of quality to their stool, and that's not good. Absolutely, it's not good.
But that seems to be stirring over what you're talking about before, and that is many of us have, bad eating habits and things. And I do know that you're going to talk a little bit about that. But that is that sometimes the cure? Change your diet. This condition's not going to keep going.
It actually can. Yeah, sometimes it's that simple. So, so what do we do if hemorrhoids prolapse? What do you do? Well, the first thing that you can do is try to push them back to reduce them. And often when it starts, the first time that it happens, usually people can do that, and you should, because it's going to relieve the symptoms a little bit.
Right.
And it may avoid it clotting off, which is what we're going to talk about in a second. So initially, at least, most of the time they can be reduced, and you're controlling the symptoms to some extent when you do that.
When you have the condition, is it like some of the other things you talk about in venous disease, that it's slow to come?
It is.
Yeah. In other words, you don't go out to dinner tonight and get hemorrhoids tomorrow.
No. It's exactly the same way, because it's a slow process where those veins are dilating, and as they dilate, they become more susceptible to the trauma of defecation, and it's just kind of a slowly snowballing kind of problem. But so the second thing that can happen is bleeding. Mm-hmm. And again, like we mentioned, that can happen with either internal or external hemorrhoids.
Can it sometimes be a lot of blood?
Sometimes it can.
Yeah.
Sometimes
scary.
it can. So, it can be scary. Yeah, people have a bowel movement and they look down and they see a bunch of blood in the toilet, and it can be concerning to say the least. But does the hemorrhoid need to prolapse in order to bleed? No, it doesn't.
Oh, okay, good.
So for instance, in the case of an internal hemorrhoid. An internal hemorrhoid is going to create fewer symptoms, so you may not have any symptoms whatsoever. And if an internal hemorrhoid is not prolapsing, you may not even know it, but it might bleed. Mm-hmm. Bleeding might be the first symptom of an internal hemorrhoid. So you have to always be concerned about that. So if it's from an external hemorrhoid, again, usually you do have other symptoms, discomfort and itching and irritation. But rectal bleeding, again, it warrants stressing once again that if you have blood that you see on stool or in the toilet after you have a bowel movement, it virtually always needs to be evaluated. Because even if you think you have hemorrhoids as the reason for that, you really need to be evaluated to make sure there aren't other worse things going on.
Yeah, and you know what? Here we are, almost a half an hour into our program talking about this, and I think it's fascinating. Number one, that we can talk about it, and number two, that people are hopefully sitting there on the edge of the seat, not hurting too much while they listen to the thing that. We have to erase the embarrassment part of it. You can't expect to get help or get treated unless you're saying, well, this is what I've got.
Yeah.
This isn't something you can phone in for.
Right.
You have to, somebody's got to look at you.
Yeah, exactly. I think that needs to be stressed too. You shouldn't be embarrassed because, most people are, but most people still are when they come into our office. I know if they say, I've got these varicose veins, but listen, Doc, I got to talk to you about one other thing. Yeah. It's still hard to talk about, and, that's understandable. But in the end, it's going to, excuse the expression, in the end, it's
all going to work until it's out. Yeah. But I'm more concerned with somebody that ignores it.
Yeah. Oh, yeah.
On a trip or on a camping trip, on an overnight, or heaven forbid, being on tour somewhere, or being on the mainland, traveling around a lot.
Yeah.
And having to go through that discomfort. Now, and imagine some of it can end up being a bigger problem.
Oh, yeah. Sure.
Okay.
So the last thing that can happen is thrombosis. The hemorrhoid can suddenly clot off because, hemorrhoids have blood going through them. And that can happen. And that's sort of the equivalence of something that we've talked about before, superficial venous thrombosis. Something that we typically call phlebitis. On the leg, that's exactly what's happening there. Phlebitis basically is a superficial dilated vein that for whatever reason decides it wants to clot off suddenly. And that can be quite, that can be quite painful.
Is this something that is more prevalent through pregnancy? I mean, I do know that we have a lot of issues. That ladies have a lot of issues. It's a wonder that they'll ever have another babies. They go through so much. But isn't that when you're also pretty susceptible to that?
It is. Not only developing hemorrhoids, a lot of women, have hemorrhoids during their pregnancies. Yeah. Usually, most of the time, it recedes. Very not uncommonly, women will develop hemorrhoids, and they will go have thrombosis, clotted off hemorrhoid, and unfortunately, there are not a lot, can be or is typically surgically done, but there are ways to make that person as comfortable as you possibly can.
Which is the object of this, by the way. If you're hearing anything that sounds a little bit like you, or if maybe a spouse or a loved one or a child has shared that, that's halfway there. Mm-hmm. I mean, if you're motivated to get motivated, we're talking, major improvements in some of our listeners' lives.
Right, right. So what do we do for a thrombosed hemorrhoid? Well, you typically you have to kind of make the decision: are the symptoms bad enough to warrant incising that hemorrhoid and
which is a surgical process?
Minor surgical. Evacuating the blood to relieve symptoms. Sometimes that is done. Other times we try to treat it medically and kind of superficially and try to kind of get them through the process without making an incision. But that doesn't do anything for the hemorrhoid itself. Mm-hmm. The hemorrhoid's still going to be there. You're just, relieving or treating that sudden thrombosis.
Which a lot of people, that's pretty important, though, isn't it?
Sometimes you have to do that because they can be very painful.
If you've been listening to the program, and by the way, I've been remiss. You can find out about this and everything else by going to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. We talk a lot about, in the regular shows that we do, talk about veins, particularly people that are standing up for work and they have problems with their legs and they can't get through the workday. We also have an awful lot of people that work sitting down.
Yes.
And that if that's a part of your body that's jammed up, you're not going to have a very good day at work.
Right. Yeah. Oh, absolutely. Yeah. Absolutely. So how do we, there's a grading system for hemorrhoids. I'll just, go through this quickly just for the heck of it. But, grade 1 hemorrhoids are hemorrhoids that are enlarged but not prolapsed. Grade 2 are enlarged hemorrhoids that may prolapse but spontaneously reduce. So they go back all by themselves. Grade 3 are hemorrhoids that prolapse and you have to do something to make it go back up. You can, kind of push it up basically digitally. And then grade 4 are hemorrhoids that are prolapsed. and inflamed, and you can't, reduce them. You can't put them back in.
Isn't that? Are you sometimes amazed, when you talk to others, at how large some of these things can be?
They can be big.
Yeah.
They can be big. Yeah, especially, I think some of the largest hemorrhoids that I have seen, back in my early training, unfortunately, were in pregnant women.
Mm-hmm.
They can be big and painful.
Mm-hmm.
And there's no question about that.
Do they sometimes have to be surgically removed?
They do.
Yeah.
Or absolutely.
Yeah.
Yeah. Surgery is one remedy. And we'll talk about that also in a minute. But so what are the risk factors for hemorrhoids? And again, many of these are kind of similar to risk factors for venous insufficiency of the legs, and that's why there's a fair bit of crossover, I believe. But genetics, just like vein disease.
Yeah, thanks, Mom.
Yeah. Once again.
Yeah.
Thank you, Mother and Father. Constipation and firm stools. We've already kind of talked about that. If your stool is very hard, it's going to lead to, repeated trauma of that area, and constipation because you're straining, and that also kind of leads to the whole process. Another risk factor that we mentioned, pregnancy, obesity. Age is also a risk factor as we age. All supporting tissues are kind of like getting more lax.
I'm glad you brought that up about obesity, because I can remember in some classes that I was helping, get out to some bariatric surgeons, that this is a real big problem. And sometimes it's the deal maker. It's why somebody eventually goes to get treatment, because the reoccurring problem, no matter what this person seems to do about food, doesn't seem to work. In other words, their system is so shot that they need major work done.
Right.
Yeah.
I mean, in the obese, especially in the bariatric population of obese people, I'm sure they have a tremendous percentage of people in that category that have hemorrhoids. And hemorrhoids is one of those things. I mean, it's just like diabetes, hypertension, all those other things that can be relieved if you lose weight, definitely. So
one of the things I saw in your notes, and I couldn't wait till we get to it, and that is that if you combine a lot of the other silly things that we do to our bodies, whether it's obesity, or how about if you're a obese person that also smokes 3 packs of cigarettes a day, now you got all kinds of nightmares, and they can actually be connected, right? Smoking and hemorrhoids are sometimes connected.
There is a relation between those two things. So people who smoke have a little higher incidence of, but I think you're right. If you pile on 2 or 3 or 4 of these risk factors, cigarette smoking being one of them, then you're substantially increasing your risk because of all put together. So how do we start to treat these things? Well, many things can be done by the patient themselves. Again, unless you're having rectal bleeding, which, definitely needs to be looked at by a professional. But many of the things that we initiate are topical and local. Not only bleeding, but any persistent mass that you feel, in that area or any area for that matter. But you might have a painless mass that you're feeling around the anal area. That needs to be looked at, because you might be thinking for a long time, oh, that's just a hemorrhoid, but it may not be. It may be
same area, but not a hemorrhoid.
Yeah, it might be something different and probably much more concerning than a hemorrhoid. So, anything that persists and anything that is particularly concerning, like bleeding or masses, they need to be looked at. So, who do we send these, people with, concerning type symptoms that may or may not be related to hemorrhoids? Typically we'll send them back to their PCP, their primary care doctor, and or a gastroenterologist.
Yeah, let's talk about that gastroenterologist guy. That must be one of the most gratifying things when a person like yourself can refer somebody that is a specialist in that area, and it's predictable. What they can do is quite predictable. And that's many people might not know. What kind of doctor should I go see? Gastroenterologist, because the gastroenterologist is going to be the best one to evaluate your symptoms
and look at it from a very global sort of way, and also, most importantly, do the things that are going to lead to a definitive diagnosis.
Okay.
You want to diagnose. You want to diagnose hemorrhoids if that's what they're thinking, but you also want to make sure you want to rule out other reasons for symptoms or bleeding or mass, et cetera. So, and the gastroenterologist is the best person to look at that when it comes to GI tract sort of things. So, what do we do? Well, there's topicals. You mentioned Preparation H.
I think everybody on the planet's either seen it or thinking,
oh, yeah.
I'm glad I don't need that. But when I would imagine it can be your real friend.
It can. Yeah. I'm sure it can be, yes. Yeah. Preparation H or other things like that, can bring about a fair amount of relief, especially if your symptoms are only irritation, itching, inflammation, etc. Those are going to be addressed with topical type of medications. So if you use a little Preparation H and it goes away, then you might watch it and see how things go. If you are having symptoms and you're doing something topical, like Preparation H or whatever other type of medication, then it's not doing the trick, then you should see your physician because maybe there's something else going on. Topical ice can also be, beneficial because the ice is going to diminish the edema, the swelling, the inflammation, and again, at least address things from a symptomatic standpoint. And then, of course, you mentioned it before, sitz baths.
Yeah, for those that don't know, what is that?
Yeah, well, I think the term sitz bath probably in general referred to a specific kind of device that you sat in, and you were soaking in that area in warm water and whatever else. But you can do a sitz bath just by laying sitting in the bathtub.
Sure.
Put some warm water and whatever kind of thing you want to put in the bath, but just soaking in a warm bath is going to bring about a little bit of relief of symptoms.
From what we understand, too, somebody said that sometime a saline bath is good because it'll actually help draw out the fluid or whatever it is.
Epsom salts or something like that would, certainly is not going to hurt. So, so diet. That's the next big thing. And you really need to eat a high fiber diet if you're having problems with hemorrhoids. And it's probably the most important thing that an individual can do for themselves that may very likely lead to reversal and relief of hemorrhoidal problems. Often hemorrhoids arise again because of hard stools and straining. We've talked about that. So you want to bring about a quality of your stool that is going to be, number one, easily evacuated and on the bulky side so that it's not, hard. But
what about the other extreme? I mean, when you go to, very, very large and painful stools to a faucet, where it's turned from I'm constipated to, oh my goodness, I'm drowning.
It's unlikely you probably wouldn't get to that extreme just by changing your diet. If you if you're taking other medications, if you're taking medication for constipation, then you can certainly overdo that such that your stool becomes watery. You don't want that either, because then you're going too frequently. I think high fiber. So what does that mean? Well, that means a lot of fruits and vegetables, basically. But it doesn't. You can do other things too. I mean, I think that fruits and vegetables are in general, a good a part of a good diet. But you can also take fiber supplements.
Okay.
Metamucil.
Yeah, you see a lot of Metamucil for one.
Is one of those things, and I hear a lot of people say good things about Metamucil if they suffer from kind of a hard stool quality and they incorporate something like that, a fiber supplement, into their daily routine, then it really can, on an ongoing basis, change the quality of your stool. However, that's something that needs to be done every day. I mean, it's kind of like wearing compression stockings. Yeah. If you don't wear your compression,
that's an inside joke, folks. We haven't talked about that on this program. Not likely to get to them. But if you've got a venous condition, take it from me. I fought kicking and screaming for years, and now I'm a firm believer. As a matter of fact, I was just sharing with Doc. We haven't seen each other for about a month. That I've had my stockings on every day for 31 days in a row. It's a record.
That's a good thing.
But you see, I think that this is what you're starting to talk about now is getting some discipline in your life in order to treat this, particularly for hemorrhoids. You need to be disciplined.
Sure. So, fiber is important, and literally it can change things, immediately. And maintaining a good hydration. Water is good for a lot of different reasons, but water is also good for maintaining a good quality type stool so that you're not, dealing with hard stool and having to strain, et cetera. So I think those are the main things, topical, diet, and hydration. Those three things are probably the most important that somebody can do right now, if they're having a hemorrhoidal problem.
I'm wondering also, you mentioned earlier, and I know you're going to get into hydration here pretty soon, and I think the reason why is because sometimes when people are irritated or whatever, wherever in their body, they want to not use it. Well, unfortunately, you don't have the opportunity to not use your GI tract because every single day, 3 times a day, you need it.
Right.
And you actually need it 24/7.
Sure. Yeah. It's unavoidable. Unavoidable. So beyond what you can do for yourself, what are some of the surgical interventions? Yeah. Because there's a whole host of surgical type things. So even though hemorrhoids are very, very common, we said that 75% of adults are going to have hemorrhoid problems at one point or another. Only about 10% of those people are going to need surgical intervention. So that means that the other 65%.
I'm knocking on wood, hoping I stay in that category. In the 65 guys.
The other 65 are going to be adequately treated with fiber, diet, topicals, and good hydration. So that shows you how good those three things work. If you're conscientious about adhering to those things on a daily basis. So only 10% will need it. The various, there is a number of different approaches, but it's kind of based on, what type of hemorrhoid it is and at what stage you're at, et cetera, et cetera. But so the first thing, and probably the easiest and most reliable thing, is rubber band ligation. And
I saw that, and I thought, what in the heck is that?
Yeah. People have heard, a number of people have heard about it. I probably because there's a good number of people that have had it, but it's a procedure that is done in the office. There really is no anesthesia of any sort that you need. But it's a device that is, introduced into the anal canal, and the hemorrhoidal tissue is visualized. The excess hemorrhoidal tissue is brought, kind of sucked up into this device, and then a rubber band is deployed around the base of that, excess hemorrhoidal tissue. Now, what does that rubber band do? Well, that rubber band basically leads to, over the course of several weeks, the tissue dying essentially, and it just kind of falls off. So it kind of turns into, kind of a scabby kind of thing, and then it's just eliminated when it's fully devascularized and no longer viable as tissue. These are used primarily on internal hemorrhoids. Now, why do you not want to put them on an external hemorrhoid?
Why?
Because because there's a lot of sensory nerves in the area of an external hemorrhoid, and if you put a rubber band on it, it's going to be very, very painful. Yeah. So basically,
this is not one of these do this at home tricks.
No. This has got to be. Yeah, you don't. Don't go to the Office Depot, get rubber bands and try it at home. No. So that, again, that's probably the simplest and the most reliable way to treat hemorrhoids in the office. It's probably a very short procedure and can have very good results. Another thing that we do is sclerotherapy. That's when we inject a medication into a vein to make that vein contract and hopefully go away.
And in our normal shows, gang, we talk about that all the time.
Yeah.
And that's just a reminder. We're talking about a very specialized part of the body right now. And also, I want you to go to veinclinicsofhawaii.com to find out the scope of what we do at the clinics. And also, should you become in this category as well, Doc's going to know exactly what you need and exactly where you need to go. So don't be the least bit embarrassed if you're in there and you're doing this and doing that and you fail to mention this. You're doing yourself a disservice.
Sure, absolutely. So, so sclerotherapy is something that we inject into veins all the time on the legs and other places. But sclerotherapy is something that we can also do to hemorrhoids because they are a vascular structure. Yeah. We use some kind of chemical. I think that the chemical that is used in hemorrhoids is usually a little different than what we use on the legs, although it could be the same thing. Basically, what does that chemical do? Well, it creates inflammation inside on the inner lining of that vein, and basically it causes the vein to collapse because of that inflammation. So sclerotherapy, how well does that work? Well, it probably is not as reliable as banding, rubber banding a hemorrhoid. It would often need to be done more than once, in order to get an entire, good result.
Assuming that the experience is not so awful that you say, I'm not doing number two.
Yeah.
Yeah. So you have to have, and I'm sure that part of the process, because you said, when you're able to communicate with the patient and vice versa, that there's a lot of feel-good stuff that you're going to learn before the procedure.
Oh, yeah.
That's what's going to happen here.
Sure.
It's not going to be this big, scary mystery.
No. I think, just like the things we do in the office, we try to keep things very, very comfortable for the patient. Sclerotherapy is probably quick, easy, but not quite as reliable as rubber banding. There's something called coagulation, which is a little different than sclerotherapy because of the fact that you're using some light source, either a laser or an infrared light or some kind of heat element, but you're heating up the hemorrhoidal tissue and causing it to clot off, contract, and become less swollen and irritated. And I think that probably coagulation, there's a little bit of discomfort with that we don't see with the other ones. It's I think probably even a little less reliable than injection sclerotherapy, but it's something that can be again done in the office and is pretty easily accomplished.
At what point in time? Okay, so make sure that people understand sclerotherapy, which we've discussed many times.
Yeah,
it's kind of like isn't that a saline liquid that's in there?
Well, saline is part of it. In years gone by, when we did sclerotherapy for leg veins, we used hypertonic saline. That's probably what you're referring to.
That's what I was thinking.
We don't use that quite so much anymore. We've got a couple of other medications that work a little better, number one, and number two are not quite as uncomfortable when they're injected as hypertonic saline was.
Okay.
So then we go on to if those types of modalities don't work, or somebody might have recurrent hemorrhoids, et cetera, then you may go on to a more surgical remedy. And there's surgical excision. I mean, hemorrhoidectomy. That's what we mean when we say hemorrhoidectomy. So, this is something that's done in the operating room.
I'm imagining in a much smaller percentage of the population that are listening.
Yes, probably. Of the 10% that do need some sort of intervention, it's probably even it's a fair bit lesser percentage that actually go on to surgical. But it's done in the operating room. Typically, it's done with a general anesthetic. And this is going to be more advanced grades of hemorrhoids. So probably we're talking about grade 3, grade 4. And essentially, it's just you go in and you excise all of the hemorrhoid tissue that you see. And usually there's three little groups of hemorrhoids that, when you're looking at it anatomically. So it's a relatively quick and easy kind of surgical procedure. I remember doing a lot of them when I was in my general surgery residency. That was kind of one of the first procedures that you learned how to do.
But this is something that is commonly done as an outpatient. You walk in and you get it done. But I would imagine that there's some cases that are a little bit longer than that.
I don't. You know what? That's a good question. Yeah. Back when I was doing it in training, the people, the patient was admitted to the hospital, and they stayed for a couple days.
That's what I thought. That's what I remember hearing.
And I don't know if they're doing it as an outpatient at this time. They might be, but when we were doing it back then. We wanted to, it was important to make sure that in that immediate post-op period that, number one, they didn't have bleeding or any other problems. And then also, number two, we always wanted to keep them in the hospital until they had their first bowel movement, which was always a dramatic event.
I was going to ask you that. Then the other side of it is, of course, is that I mentioned it incorrectly earlier, and that was infection. But I would imagine that once you do have these sort of procedures done, that extra care has got to be employed immediately just to prevent that.
Yeah. Well, surprisingly, the patient may get a little antibiotic around the time of the operation. But usually they heal up very, very nicely. Infection does not seem, although you would think it would be, but infection does not seem to be a big problem with hemorrhoidectomy.
Okay.
One of the risk factors for hemorrhoidectomy is that you might damage the external sphincter. The anal canal is where we have our major sphincter that controls our bowel habits. And doesn't happen very often, but that is one of the risks of surgical excision of hemorrhoids because we're working in that area, and it can alter or damage that the muscular activity of that external sphincter.
Typically speaking, I should have asked you this earlier, and I don't want to go too far off on the sidebar because I don't want to run out of time. But let's talk about the age groups, maybe. I mean, I do know that it's an equal opportunity problem, but less likely, I would imagine, with little ones, but I don't know.
Yeah, no, children I don't think I've ever seen a child with hemorrhoids. It definitely is age related. I mean, age is one of the risk factors, and I think like venous insufficiency, it's not necessarily age; it's just time. The whatever the process is that might be happening, like genetics or standing on your feet a long time. That as we age, that those processes are going on for a longer period of time. But certainly I have seen patients in their 20s with hemorrhoids, especially again pregnancies. But of the population of people that aren't pregnant, we've seen them in that 20-30 age group. But I think by and large, it's more middle-aged and the elderly that are going to have these kind of problems.
Okay, the one other real quickie, because I saw something advertised on television.
Yeah.
And that was Crohn's disease. There's a lot of medicines and things about Crohn's disease. And so since you're talking about that area of the system, I'm imagining that people that have any of those other problems have to be particularly vigilant to guard against also having hemorrhoids recur.
Well, yes, but probably more importantly, Crohn's, ulcerative colitis, all of those inflammatory processes of the GI tract, those are also reasons why somebody might have bleeding.
Yeah, I was going to ask that too.
And that would fall in the category of, I've got blood in my stool. I think it might be a hemorrhoid, but it could be something else. So we got to make sure that those other types of things aren't happening. Crohn's would be one of them. Yeah, because you definitely, the treatment for Crohn's and ulcerative colitis is, totally different. And if you have that process, you want to know about it so that it can start being treated. So, and then the last type of surgical device is called stapled hemorrhoidectomy. This is a relatively new device. It was not around when I was a resident, but it's a device that kind of forms a circumferential staple line.
So that would be in place of a rubber band?
Inside, well,
or a different.
It works a little differently. It's advanced into the anal canal, and it's positioned in the upper area of the anal canal, or lower part of the rectum, and it's a circular kind of thing. It creates a circular staple line, so it scrunches the tissue together more than anything. And what it's doing is that it's pulling up. It's eliminating some of the hemorrhoidal tissue, but it's also pulling all of the excess tissue up, which is creating a situation where it's less threatened by all those factors that are going to irritate and create hemorrhoidal activity.
Is that done with these little cameras?
That's done. It's probably done with a scope type mechanism. Yeah. But that again is also done. It's done in the operating room, and probably a general anesthetic is utilized. People can kind of return to their normal life activity a little quicker with stapled hemorrhoidectomy as opposed to surgical, and it's a little easier to get over.
We're going to have to come back and revisit this, that's for sure, Doc. Great information, and once again, you can find out even more at Vein Clinics of Hawaii. That's veinclinicsofhawaii.com. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.